So welcome again to our YouTube channel at MedClinch Academy. So if you are new, please make sure that you subscribe, press that like button, and also share our link. So we are on our second series on hypertension and antihypertensive. If you're watching us for the first time, please make sure that you go back and watch our first two episodes. So in our first episode, we looked on the definition of hypertension and also looked on the grading of hypertension and further looked on the types of hypertension. That's the primary hypertension and secondary hypertension. We also looked at various parameters that are used to calculate and to define hypertension, the likes of the cardiac output, the stroke volume, the total peripheral resistance, the end diastolic volume, the end systolic volume, the preload, and the afterload, and others. So make sure that you watch our first episode. On our second episode, we looked on sympatholytics or sympathetic antagonist, the drugs that work by going against the sympathetic drive. If you haven't watched that episode, please go back and watch it. So today we're going to go direct on our third episode of this series, and we are going to basically look on the renin-angiotensin-aldosterone inhibitors. Remember, on our second episode, I told you guys that we are going to have an understanding on how the RAS system works and the drugs that work against the RAS system. So this class, we are going to look on the drugs that work against the RAS system. But before that, we have to go back to our physiology class and remind ourselves of the RAS system. What is the RAS system? How it works, and how the drugs work against this system. So our introduction first is to have an understanding on the renin-angiotensin-aldosterone system. Now, one thing that you have to know, or one thing that you have to remind yourself on, is that kidneys is a very special organ. It not only filters our blood, but it also makes a special molecule that is called renin. So our first step of this system, just as our headline states, is renin. So you have to understand what is renin. So renin is a molecule, a special molecule that is produced by our kidneys. So kidney is a very special organ when it comes to this system. Then now, our second point, remember our previous episode on sympatholytic drugs and understanding the sympathetic system? Yes, today also you're going to have something that you have to remind yourself on, is that the beta 1 receptors are also found in the kidney. Remember on episode 2, I told you guys that beta 1 receptor, number 1, they are found and located on the heart, and another one are located on the kidney. The beta 2 are found on the bronchial muscles. So beta 1 receptors that are found on the kidney, they're always stimulated by the sympathetic nervous system. And once that happens, the special cells in the kidney called the juxtaglomerular cells will now pump out our renin. Yeah, so that tends to happen. Remember, the sympathetic nervous system, its major aim is always on the increase of blood pressure. So beta 1 receptor, one thing that they also do, despite of increasing the heart rate and increasing the heart contractility, they also have an impact on the kidney, whereby when stimulated, they push or they urge the juxtaglomerular cells to release the renin. So uh, apart from the sympathetic nervous system stimulating the juxtaglomerular cells to release the renin, we also have got other mechanisms that will stimulate our kidneys to release the renin. And that, number one, is when there is a decreased perfusion to the kidney. Remember, one thing that we know is that during shock, when the client has lost a lot of fluids, maybe through blood loss, hemorrhage, or maybe through dehydration, or maybe hypotension, the kidneys will be hyperperfused. And when the kidneys are hypoperfused, it will signal the juxtaglomerular cells to release out the renin. So these are other mechanisms that promote the release of the renin. Number one is the activation of the beta 1 receptors via the SNS. Number two is the decreased perfusion of the kidney that may happen either when the client is dehydrated or when there's blood loss or when there's hypotension. So the juxtaglomerular cells will release the renin. So our renin has been released. Now what is our next step? So once renin is produced, it will interact with another molecule or with another special uh, protein or factor called angiotensinogen, and this one is being produced or being made in the liver. So liver is another organ that is involved in this system, and the function of the liver majorly is to produce the angiotensinogen. That is another crucial molecule that is being released by the liver. Now, once that happens, now we have got our renin and we have got our angiotensinogen. What happens? Now, renin basically will convert the angiotensinogen that has been released by the liver to angiotensin 1. Now, we have got our angiotensin 1. Now, the next step is that our angiotensin 1, once it reaches the lung, there's a powerful enzyme that the lung produced, and that enzyme is called the angiotensin converting enzyme, or the ACE. So, the angiotensin converting enzyme will now convert the angiotensin 1 to angiotensin 2. So, I hope till there we are together. Remember, our final product here is the angiotensin 2. Angiotensin 2 now is the culprit that works on various organs to ensure that our blood pressure has been increased. So that you should not forget. Now, our angiotensin 2 now will act on different tissues or different organs. Our first organ, there is the heart. It will act on the central nervous system. A specific area in the CNS will be acted upon by our angiotensin 2. It will also act on our adrenal cortex. It will act on our kidney tubules and also act on the blood vessels with an aim of increasing the blood pressure. Now you're going to look on how angiotensin 2 works on these organs and how it impacts this organ to increase the blood pressure. So let's begin with our first. Remember, I've told you that angiotensin 2 works on our blood vessels. To be more specific, on our arteries and our veins. How does this happen? So our first is blood vessels. How does this occur? So angiotensin 2 acts on blood vessel to do what? Now, angiotensin 2 receptors, the 81 receptors on the arterial and venous smooth muscle attach to angiotensin 2, causing contraction. So it means once the angiotensin binds to the angiotensin 2 receptors, it will lead to vasoconstriction of the vessels. So number one, it leads to arterial vasoconstriction. And remember from our episode 1 on hypertension and the parameters that increase hypertension, we know that when this arterial vasoconstriction, it will automatically lead to an increase of the systemic vascular resistance or the total peripheral resistance. So when there is an arterial vasoconstriction, this leads to an increase of SVR or TPR, or you can say also the afterload. Yeah, don't forget that. And also once you increase SVR or the TPR from our formula of calculating blood pressure, BP equals cardiac output multiplied by the TPR or SVR. So when you increase the SVR and our cardiac output is constant, automatically that will lead to an increase in blood pressure. Apart from that, it will also lead to venous constriction. And unlike the arterial vasoconstriction, the venous constriction leads to an increase in the preload. And we know when the preload is increased, our end diastolic volume increases. And if increase our end diastolic volume, automatically, as long as our ESV remains constant, that will lead to an increased stroke volume. And when you increase stroke volume, you increase our cardiac output and largely you increase our blood pressure. So that's what you have to understand in this slide, that our angiotensin 2 acts on blood vessel. We have got the artery and the vein. So it will, if you constrict our artery, that will lead to an increase of SVR, TPR afterload, which will finally lead to an increase in BP. And when you constrict our vein, you are basically increasing the preload, because remember, when you constrict the veins, you are basically increasing the venous return, and if you increase the venous return, you are going to make the ventricles to stretch further, increasing the end diastolic volume, and that will lead to an increase in stroke volume, an increase in cardiac output, and finally an increase in blood pressure. I hope you guys have understood this slide. Allow me to move on the next slide. For those taking notes, please, this is a video. You can just forward backwards and rewatch what I'm just saying and explaining. Now, another area that our angiotensin II works on is our adrenal glands. For those guys who skipped our anatomy classes, remember adrenal glands are located on the top of the kidneys, as you can see in our diagram below. This triangular like shaped, and it has got two distinct areas. It has got the adrenal medulla and our adrenal cortex. If you want to have a clear understanding on its anatomical structure, please go back to anatomy notes and look on how it looks like and which areas and how these areas release various hormones. Now, let's just skip on our today's message. Angiotensin II also acts on the adrenal gland. To be more specific, it acts on the adrenal cortex. And how does that occur? Angiotensin II acts on the adrenal cortex to produce aldosterone hormone. Now, aldosterone hormone is a very special hormone in that it works on the kidneys, on the kidney tubules to be more specific. Now, aldosterone, it always acts on the kidney and leads to retention of sodium. And we know that if you retain sodium, automatically you will retain water. So it retains sodium and water. But also one thing that you have to remember is that apart from that, it also leads to excretion of potassium. So aldosterone always retains sodium, but it removes potassium. So it promotes the release of potassium in urine. So one thing that I want you guys to know is that when we look on diuretics in our next class of antihypertension diuretics, I'm going to explain further when you look at potassium sparing diuretics, how that happens and the mechanism under which it occurs. But for today, just know that angiotensin II works on the adrenal cortex to produce aldosterone hormone, and once you have the aldosterone hormone, that hormone always leads to retention of sodium and water, but also leads to an excretion of potassium. That's something that you have to know. Now back to our class. Now, once you retain water, what happens? This will lead to an increase in the venous return, yeah, automatically leading to an increased preload. An increased preload, we know that it will lead to an increased EDV, increased stroke volume, and also cardiac output, and largely blood pressure. So that's what you have to understand, is that when you retain a lot of sodium and water, you are basically increasing the blood volume, and that will increase a lot of venous return, stretching the ventricles further, increasing the preload. When that happens, the stroke volume will be massive, and cardiac output will increase, and finally there will be an increased blood pressure. So that's what you have to understand, that angiotensin II also works on the adrenal cortex to increase blood pressure. I hope we have understood. So allow me to move to our next slide. Remember, we can always forward backwards. This is a video that you can just watch at your own free time, and if I have mentioned something that you don't understand, just forward backwards and you can always understand what I'm trying to say. That's my point here. Aldosterone also causes potassium excretion. Never forget that crucial point. Next, remember I told you guys that the angiotensin II also has got some impact on the CNS. There's a specific, very crucial gland that we know. It's called pituitary gland. We know that it has got two sections, the posterior section and the anterior section. Or if you do anatomy, you're going to hear the term the adenohypophysis. Yeah, those terms that we use in anatomy. But for today, just remember that there's a special area in our brain that plays a crucial role in releasing hormones. Now, I'm just going to take you backwards now. Angiotensin II is always produced in the posterior pituitary. So angiotensin II also stimulates posterior pituitary to release ADH hormone, and once the ADH is being released, ADH is also called vasopressin. Yeah. So when the ADH is released, ADH always leads to the reabsorption of water in the kidney. Yeah. So ADH acts on the aquaporins, increasing water reabsorption. And when you increase water reabsorption, what means? It means that you are going to increase the blood volume. And when you increase the blood volume, you are increasing the preload, you are increasing the stroke volume, you are increasing the cardiac output, and finally you are increasing the blood pressure. So angiotensin 2 also has got an impact on the ADH release. Now, our continuation now next is the kidneys. Now, what's the role of the ADH? What is the role of angiotensin 2 on the kidneys? Now, on the kidneys, there's a special thing that happens when it comes to angiotensin 2 action on the kidney. Remember, you guys will be taught something called GFR, but today I'm just going to basically just pass through. In future, we're going to have a clear understanding on how filtration process occurs. But for today, we're just going to look on the action of angiotensin 2 on our kidneys. Now, angiotensin 2 also acts on the arterioles of the kidneys, constricting the efferent arteriole more intensely than the afferent arteriole. Remember, if you look at the glomerular structure, you know that we always have the afferent arteriole, the glomerular capillaries, and lastly, you've got the efferent arteriole. Now, for you to increase the filtration pressure, what happens? You have to constrict the efferent arteriole more. So angiotensin 2, what it does is that it constricts the efferent arteriole more than it does the afferent arteriole. And when you do that, what happens? You are going to increase the glomerular blood pressure, increasing filtration rate. And once you increase the rate of filtration, it means that you're going to increase the protein loss, and further, you're going to thicken the glomerular basement membrane. Why is this important? This is important because when that happens, the massive GFR, massive protein loss, and thickened basement membrane may propagate the CKD, or the chronic kidney disease. So that's something that you have to understand when it comes to this action of angiotensin 2. I'm trying to stress this point is that you have got some drugs that are very useful when it comes to treating clients with DM type 2, because those clients with DM type 2 they always have something called nephropathy. So if you are trying to save the kidneys, those clients with DM type 2, you always see them having the drugs that work on this system. So just hold on, have this point at the back of your mind. When you look at our next episodes, I'm going to try and explain why this slide was crucial for our lesson. So remember, angiotensin 2 always have an impact on propagating CKD because it increases the glomerular pressure and the rate of filtration. So that's something that we have to put it at the back of your mind. We're going to explain further. So I don't want to touch on the anatomy of the kidney, but this is the gross structure and this is the microscopic structure. If you're not able to understand the kidney, please go back on your anatomy section, look at the structure of the kidney, on the gross structure of the kidney, also the microscopic structure and the physiology behind how the urine is being formed. Once you have that understanding, then it becomes easy for you to understand how the drugs work. Now, let's go to our heart. Angiotensin 2 also has an impact on the heart. How does it impact the heart? So angiotensin 2 has got a positive inotropic effect on the heart. When you hear the term inotropic effect, I hope you guys know what I mean. If you don't understand what I mean, please go watch our previous episode. I really explained the terms inotropic, dromotropic, and also chronotropic. So if you don't understand those three terms, please watch our previous episodes. But back to our class, angiotensin 2 always play a crucial role in our heart, in that it has got a positive inotropic effect. What does this mean? This just means an increase in the force of myocardial contraction. Yeah. So by increasing the availability of intracellular calcium within the cardiomyocytes, angiotensin 2 slightly increases the force of myocardial contraction and to help the heart pump against higher pressure. Why am I trying to enforce this point to you guys? Remember, you guys, what we learned concerning the cardiac output. Remember when we explain the stroke volume, we said that the stroke volume equals the end diastolic volume minus the end systolic volume. Now, if you increase the force of contraction of the heart, it means that the ESV, the end systolic volume, will decrease because the force of contraction is very massive, pumping a lot of blood. There will be an increase in the ejection fraction. Yeah, a lot of blood will be pumped out of the heart. So if you increase the force of contraction, you are basically increasing the ejection fraction and decreasing the end systolic volume. If you decrease the ESV, if you decrease the end systolic volume and the EDV is constant, it means that you are increasing the stroke volume. And when you increase the stroke volume, it means you are increasing the cardiac output and the blood pressure. So the positive inotropic effect leads to an increase in blood pressure. That's something that you have to understand. But point that you have to understand also, this is another thing that I want you guys to go and look at. Go and study a drug called digoxin. It's a very special drug in that it has a positive inotropic effect, but also it has got a negative chronotropic effect. So that is something that we're going to look in later, the cardiac glycosides. But for today, just let us just focus on the impact of angiotensin II on the heart, and that is that it has got a positive inotropic effect. I hope you guys have understood the function of angiotensin II on the blood vessel, on the kidneys, on the heart, and lastly, I think I've explained all of them. So this is the last point that I guess you need to understand, that when you increase the force of myocardial contraction, you're increasing the stroke volume, the cardiac output, and also the blood pressure. So that's something that you have to note and understand. Let's continue. I think I've explained everything here. This is just a multi-organ DRAS hormonal cascade. In this diagram, you can see various organs. You can see the kidney. The kidney here is where the renin is being released in the juxta glomerular cells. In the liver, here is where the angiotensinogen production occurs. And we know that the renin acts on the angiotensinogen to convert it into angiotensin I. Then in the lungs, we've got the ACE, the angiotensin converting enzyme that converts our angiotensin I to angiotensin II. Once that occurs, the angiotensin II now works on various organs. It works on the adrenal cortex, leading to the release of the aldosterone hormone. The aldosterone hormone, which is a mineralocorticoid hormone, what it does is that it leads to retention of sodium and water, but also leads to excretion of potassium. Apart from that, it also has got an impact on the blood vessels, whereby it leads to arterial vasoconstriction, leading to an increase in SVR and blood pressure. It also leads to vasoconstriction, leading to an increased preload and an increased BP. It increases the force of cardiac contractility, and when this happens, this will lead to an increased cardiac output. And also remember that it also acts on the proximal tubules. Yeah. There's also sodium reabsorption that occurs in the kidneys, which lead to water retention. So this is all that you have to know. It's just a simple diagram, a simple cascade that will help you understand what you've discussed when it comes to the RAS system. If you see our last diagram here down here, you can see how it begins. A decreased perfusion of the kidney when there's hypovolemia or the hypertension. When the kidney is hypoperfused, this will stimulate the kidney to release the renin hormone. When renin is released in the kidney, it will act on the angiotensinogen, which is released by the liver, converting it to angiotensin I. Angiotensin I now also will be converted to angiotensin II by ACE, the angiotensin converting enzyme, which is found on the lungs. That leads to aldosterone hormone production. Angiotensin II also acts on various organs, leading to an increase in blood pressure. Till there, I hope you guys now have understood how the RAS system works. If you haven't understood, please forward backwards, rewatch what I've just said. And also, you have books, yeah, go in Ross and Wilson, look on how this system works, and just understand that system. So once you have an understanding of how this system works, now we can go and look on the drugs. Now, let's look at the drug classification, some of the drugs that work on this system. Remember, This system is our enemy because this system leads to an increased blood pressure. And our aim is anti-hypertension. We are trying to go against this system with our aim being with our aim remaining our aim is to decrease the BP. So we have to go against this system. We have to work against the RAS system for us to increase our for us to decrease our blood pressure. So that being said, I'm going to just mention some of the drug classification, some of the drugs that work on this system. So drugs that fall under the category of renin-angiotensin-aldosterone inhibitors can be divided into four categories. Namely, our first one is angiotensin converting enzyme inhibitors, drugs that go against our ACE. Remember, it's ACE. What it does, it converts our angiotensin 1 to angiotensin 2. So we don't want that to occur. And the only way in which we can prevent that from occurring is by going against that enzyme, by going against our ACE. Our second one is angiotensin II receptor blockers. We also want to go against the receptors where the angiotensin II attach themselves in. So once we block their receptors, it means our angiotensin II won't be effective. It won't have an impact on those various organs. We can also work against the aldosterone antagonist. But this one I'm going to explain further when you look at potassium sparing diuretics in our next class on diuretics. But for this session, I'm just going to touch on the drugs that work against aldosterone. And lastly, our renin inhibitors. We can also act on the first stage of this cascade, whereby renin is being produced. You can prevent the production of renin. And once you prevent the renin production, it means that this system won't work. Yeah, and let's begin. Our first one is the angiotensin converting enzyme inhibitors. Now, I'm certain you guys, for those who are working or for students, if you're the drugs that end with the suffix prils, yeah. So if you see prils, just know that these prils are our angiotensin converting enzyme inhibitors. So angiotensin converting enzyme inhibitors, class of cardiovascular and renal medications. That these are class of cardiovascular and renal medications that modulate the renin-angiotensin-aldosterone system. And this class has evolved into a first-line therapeutic intervention for managing hypertension, heart failure, and CKD. As I told you guys, why it's important for you guys to understand how angiotensin II impacts our filtration process. So that being said, they also play a crucial role in CKD management. So some of the drugs that fall under this category are the drugs that end with suffix prils, like the enalapril, the lisinopril, the benzopril, and the captopril. See, these are example of drugs that fall under ACE inhibitors class. So that's our enalapril, very common, very good medication, our antihypertensive medication that you guys have come across. It's always in 2.5 milligram tablets. We also have got our captopril. I'm sure you guys have come across it. And we also have our benazepril. So these are some of the drugs that that fall under the category of angiotensin converting enzyme inhibitors: the enalapril, the captopril, the benazepril, the lisinopril. These are some of the drugs that can be used as antihypertensive. And remember, these drugs fall under the angiotensin converting enzyme inhibitors. They inhibit the angiotensin converting enzyme. Remember that enzyme is always produced in the lungs. Now, as we continue, let's look at the mechanism of action. Our angiotensin converting enzyme primarily exert their therapeutic effects by competing with endogenous substrate for the active sites of the angiotensin converting enzyme. So basically, our drugs are competing for the active sites of the ACE. Now, by blocking this conversion, angiotensin converting enzymes significantly reduce circulating tissue concentration of angiotensin II. So what happens? So these drugs basically they're trying to compete with the ACE for the active sites on the substrates. And when that happens, it means that the angiotensin II level won't be effective, or the angiotensin II levels will drop. yeah, it will be dropped, because remember the ACE, the major action of ACE is to convert angiotensin 1 to angiotensin 2. So if you inhibit this enzyme, it means there will be a decrease in the production of angiotensin 2. There will be a decreased level of angiotensin 2, and when that happens, this will lead, number one, it will lead to a reduced arterial and venous constriction. Remember, our angiotensin, our one major mechanism under which angiotensin 2 increases our blood pressure is once they attach to the 81 receptors, they always lead to arterial and venous constriction. Now we have got a reduced level of angiotensin 2. And when that level reduces, it means that there will be a reduced arterial and venous constriction. When you reduce arterial constriction, you are basically reducing the systemic vascular resistance and the afterload, or the TPR. And when you reduce the TPR, you are decreasing the blood pressure. When you decrease the venous constriction, it means that you are decreasing the venous return, decreasing the preload, decreasing the EDV, decreasing the stroke volume, decreasing the cardiac output, and decreasing our BP. It also leads to a decreased ADH production. Remember, ADH, or the vasopressin. Number one, the ADH is also called vasopressin. Number one, ADH, number one, leads to water reabsorption from the kidneys, which leads to an increased venous return, an increased preload, an increased stroke volume, an increased cardiac output, and an increased BP. Apart from that, our ADH also vasopressin, it also tends to constrict our vessels. So one major aim is that when we have a decrease in angiotensin 2, there will also be a decrease in ADH production. Number three, it also reduces the production of the aldosterone hormone. Remember, aldosterone hormone always leads to the reabsorption of sodium and the excretion of potassium. So we want to promote that. One thing that we have to note here is that when you reduce aldosterone production, it means that you're going to reduce sodium reabsorption, but you're going to promote potassium. You're going to promote potassium retention. Potassium will be retained. Yeah, don't forget that. So our angiotensin converting enzyme inhibitors, they always lead to hyperkalemia. I'm going to show you how that occurs in a while. One thing that you have to remember is that this also leads to a reduced glomerular pressure. Remember, our angiotensin 2 always leads to an increase in the glomerular pressure by promoting the constriction of the efferent arteriole more than the afferent arteriole. So when you decrease the level of angiotensin 2, it means that you're going to reduce glomerular pressure. So let's continue. Our angiotensin converting enzyme inhibitors also act on a very crucial pathway. There's a very crucial pathway called the bradykinin pathway. Our angiotensin converting enzyme is very crucial when it comes to this pathway. Now, bradykinins are little molecules that are acted on by angiotensin converting enzyme to active metabolites. So bradykinins, these molecules, they're very cheeky molecules. We always want to convert them into active metabolites. And the only way to do that is always the enzyme that's always involved here by converting bradykinin into active metabolites. The enzyme involved here are the angiotensin converting enzyme. Now, the angiotensin converting enzyme inhibitors reduce their conversion, increasing bradykinin levels. So when you stop this enzyme, it means you are going to increase the levels of bradykinins. So that's one of the major side effects when it comes to using these drugs, is that despite decreasing our BP, you are going to increase an enemy. You're going to increase bradykinin levels, and that's something that we don't want. Why? Because an increased bradykinin levels leads to, number one, dry cough, and also it leads to angioedema, and that's something that you want to avoid. Now, these are a small cascade that I derived on how this happens. Now, when ACE stands for angiotensin converting enzyme. You can see here, down here, we have our abbreviations. The ACE stands for angiotensin converting enzymes. NO stands for nitric oxide. PGI2 stands for prostacyclin, and BP stands for blood pressure, obviously. Now, you have got a green side and a red side. Green side here shows when the ACE is active, or normal, what happens? Remember, a bradykinin is formed. There's a chart. I will process how this happens. I'm not going to go into it because of time, but if you want to, I can share a link on how that occurs on some documents that shows how that occurs. But for today, just know once bradykinin is formed, we have got the ACE, the angiotensin converting enzyme. They always degrade bradykinin, and when that happens, there's always a decreased bradykinin level, and when there's a decreased bradykinin level, also there will be a decreased a nitric oxide level and a decreased prostacyclin level. When this happens, there will be vasoconstriction and normal permeability and maintained BP. So from this, you have to know that bradykinin always leads to an increased nitric oxide and prostacyclin. Now, other side now is how this happens. When you're using inhibitors or drugs that inhibit this enzyme, what happens is that when you inhibit ACE, there will be an increased level of bradykinin. The bradykinin will accumulate. And when bradykinin accumulates, it means that there will be an increased level of nitric oxide and increased level of prostacyclins. And when this happens, there will be vasodilation, increased permeability, and a decreased blood pressure. Yeah, so I want to focus more on here permeability and vasodilation. Yeah, I'm going to explain further how this happens and how angioedema tends to occur. But there's a key point here that you have to know. Angiotensin converting enzyme reduce bradykinin levels. Now, if you inhibit ACE, this leads to bradykinin accumulation, causing vasodilation and increased vascular permeability. What happens when there's an increased vascular permeability? It means that there will be fluid will flow from the intravascular space into the interstitial space, and this leads to edema. So that's something that you have to know or to understand. So one of the major adverse drug reactions that you have to know when using these drugs, number one is hyperkalemia. Remember, guys, I told you guys that one thing that you have to note is that hyperkalemia, for those guys who maybe are new, hyperkalemia means elevation of potassium levels above their normal. And I think the normal potassium level is always around 3.5 to 5 milliequivalent per liter or millimole per liter. Now, hyperkalemia means an increased level of above 5 millimole per liter. So, one of the major drug reactions when using this drug, one of the major adverse effects when using this drug is hyperkalemia. There will be elevation of potassium above 5 millimole per liter. Now, how does this occur? By reducing circulating angiotensin II, angiotensin converting enzyme inhibitors suppress aldosterone secretion from adrenal cortex. Remember, you guys, I told you guys that one of the major aims of angiotensin II is always the production of aldosterone hormone from the adrenal cortex. Aldosterone always acts on the kidney tubules to promote sodium absorption or sodium reabsorption, sodium and water reabsorption, but also it leads to potassium excretion. Yeah. So when you suppress aldosterone, it means that you're going to retain more potassium, and you're going to release or to excrete sodium. So that's the point that I'm trying to explain. There will be a lot of potassium retention. So a reduction in aldosterone hormone or a suppression of aldosterone leads to retention of potassium and excretion of sodium. Don't forget that point. Because aldosterone is responsible for excreting potassium in exchange for sodium reabsorption in the collecting ducts, its absence leads to renal potassium retention. Let me just highlight this in red because this is a very crucial. This is a very crucial part that you have to know. It leads to renal potassium retention. So don't forget that it leads to renal potassium retention. That's something that you have to understand when it comes to angiotensin converting enzyme inhibitors. And for those guys who doesn't know some of the signs and symptoms of hyperkalemia, number one, the client may present with muscle weakness, be very crucial, or there'll be maybe oliguria or anuria. There will be resp distress. There will be a decreased cardiac contractility. There also may be an EKG changes, peak T waves, if you see the EKG reading, you may see a peaked tented T waves, but also a wide on. Also remember, a wide QRS may also be seen when using this drug. So if the client is under EKG monitoring, you see there's some EKG changes, the T waves are peaked and tented, and you see a wide QRS. Be very vigilant. The client may be having hyperkalemia, and also it may cause hyperreflexia or hyporeflexia. So these are some of the symptoms of hyperkalemia that you have to know. And remember, we are going to create some a mini series on how you can manage hyperkalemia. But for today, just know that when using these drugs leads to retention of potassium. There will be an increase in serum potassium. Another reaction that I want to explain is the angioedema. As you can see in this diagram, the client has got angioedema. This happens because, remember, an increase in the bradykinin levels leads to vascular permeability, and this will promote the release of fluids from the intravascular space into the interstitial space. This tends to happen in the submucosa, in the underneath the skin, as you can see here. Can be seen in the face, in the lips, in the tongues, in the glottis, in the larynx. And that being said, be very vigilant because it may lead also to difficulty in breathing. The client may also have difficulty in breathing because it may also happen in the airway. So be very vigilant when it comes to using these drugs. So it is driven by excessive local accumulation of bradykinin, I've explained, which causes profound localized vasodilation and increased vascular permeability. That I've also explained. When using these drugs, it may increase vascular permeability. How and when you increase vascular permeability, you're going to promote a lot of fluid flowing from the intravascular region into the interstitial region, and that leads to edema, as you can see in our diagram. Apart from that, same. Another impact of having an accumulation of bradykinin, it may also lead to dry, non-productive cough. So it is caused by the accumulation of bradykinin, substance P, and prostaglandins in the resp tract, which hypersensitizes local cough reflexes, as you can see. Now, if in a exam, as you can see, maybe this is a sample from a question that I saw somewhere, explaining which drug class is most likely to cause dry cough in a patient with hypertension. So if a client is using antihypertensive and the client suddenly develops dry cough, persistent dry cough, there's a higher chance that this client, the drug that is causing this is angiotensin converting enzyme inhibitors. So here our answer will be choice A. So angiotensin converting enzyme inhibitors leads to an elevation of bradykinin, which will lead to dry, non-productive cough. Now let's go to our second drug class, and that's our angiotensin II receptor blocker. So this is a keyword here, receptor blocker. It blocks the angiotensin II from binding to its receptor, the 81 receptors. Now, unlike the angiotensin converting enzyme inhibitors, which block the synthesis of angiotensin II, our angiotensin receptor blockers allow angiotensin II to be produced, but competitively block its binding to the 81 receptor, the angiotensin II type 1 receptor. So that's happened. So the main mechanism of action of this drug is that unlike the ACEs, these drugs they block the angiotensin II from binding to the 81 receptors. They basically block the receptors. So that's one thing that you have to understand when it comes to using these drugs. So these drugs include the Satan. You see the losartan, the candesartan, and the valsartan. Yeah. So this, if you just hear the term Satan, just know that those are the drugs that fall under the ARBs, the ARBs. Yeah. So that's what you have to know when it comes to these drugs. They are the suffix sartan, losartan, the candesartan, and the valsartan, and other sartans. These drugs, the major aim is to block the angiotensin II from binding to its receptor. So these drugs bind on all receptors of angiotensin II. So this will, number one, as we know, it will reduce the arterial constriction and also the venous constriction. If you reduce the arterial venoconstriction, if you reduce the arterial constriction, it means you are reducing the SVR and in turn reducing the blood pressure. If you reduce the venous constriction, it means that you're going to reduce our preload, reducing the stroke volume, reducing the cardiac output, and reducing our blood pressure. Don't forget, it also reduces the ADH production, as we know, and also reduces the aldosterone production. So very similar to the ACE1s, yeah. And the same thing that you have to note, it also reduces glomerular pressure. Very crucial. Now let's look at the mechanism of action when using this drug. So the angiotensin 1 or the angiotensin type 1 receptor, we know that it's always located in the vascular smooth muscles, in the adrenal cortex, in the kidneys, in the heart. So what happens that the angiotensin 2 always bind to the 81 receptors, the angiotensin type 1 receptors. And these receptors are located on the sites under which the angiotensin 2 acts on, the legs of the vascular smooth muscles, the venous, the arteries and the veins, the adrenal cortex, where it leads the production of the aldosterone hormone, in the kidneys and in the heart. So once you block these receptors, this will lead to, number one, vasodilation. There will be the direct relaxation of vascular smooth muscles. And when this happens, this leads to a decreased SVR, which leads to a decreased blood pressure. It may also lead to a decreased preload. Yeah, when it leads to vasodilation in the veins. Apart from that, also it may lead to decreased aldosterone secretion, reduces sodium and water retention in the distal tubules, decreasing intravascular volume. But apart from that, also we know that when you decrease this aldosterone secretion, apart from decreasing sodium retention, you are going also to promote the retention of potassium. So that's something that you have to note. Let's continue our continuation now. There's something that is called bradykinin distinction. Remember, there's something you have to know. The adverse effect when it comes to ACEIs or the ACE inhibitors, whereby ACE inhibitors leads to accumulation of bradykinin. The ARBs or the angiotensin receptor blockers, they have no impact on the angiotensin converting enzyme. They have no impact. For these drugs, they only block the receptors. So that being said, it means that our ACE will be there, and there'll be no impact when it comes to levels of bradykinin. Yeah, so that you have to understand. My point here is that when using the angiotensin receptor blockers, we will not see the coughs, the dry coughs, or the angioedemas that we saw when using the angiotensin converting enzyme inhibitors, because the angiotensin receptor blockers, they don't have an impact on the angiotensin converting enzymes. And because they don't have an impact, it means there will be a breakdown of bradykinin as normal. So they do not prevent the breakdown of bradykinin. So that you have to understand. So our ARBs, our angiotensin receptor blockers, they do not cause angioedema or they do not cause dry persistent coughs. That you have to understand. Yeah. So consequently, bradykinin levels remain normal. Yeah, they remain normal, making the development of dry cough or bradykinin mediated angioedema exceedingly rare compared to angiotensin converting enzyme inhibitors. That's something that you have to note. So you may see maybe a client who is using enalapril, who develops a dry persistent cough or has got angioedema. You may see the doc maybe switching from enalapril to maybe a losartan or a candesartan. Yeah, so because the statins they do not have an impact when it comes to bradykinin levels. We have our drugs here. This is called valsartan, 40 milligram. We have got our cansartan, but the term here is the candesartan silexetil. We have our losartan. I think this is very common. You guys have, I know you have come across this losartan potassium, 50 milligram. Continuation. Let's continue. So angiotensin receptor blockers and our angiotensin converting enzyme inhibitors are common utilized drugs. These drugs are very common. I'm certain you guys, if you go to a medical ward, there's high chance you're going to come across these drugs. Or if you see a client being treated on hypertension, you won't be surprised if you see one of the antihypertensive is either an angiotensin converting enzyme inhibitor or it's an angiotensin receptor blocker. So very similar adverse effects when it comes to using these drugs. you see hyperkalemia, very similar to when you saw when using ACE inhibitors. There's also a creatinine increase. Why does this happen? Remember, there's always a flow of how this occurs. Angiotensin II always leads to angiotensin II. If you decrease angiotensin II, they're going to lead to efferent arterial dilation, and the efferent arterial dilation is going to decrease our GFR, and a decreased GFR is going to lead to an increase in the serum creatinine. So a decrease in angiotensin II will lead to an efferent arterial dilation. An efferent arterial dilation is going to lead to a decreased GFR, and a decreased GFR is going to lead to an increased serum creatinine. So that's something that you have to know. Yeah, that's why it tends to propagate CKD. It's also teratogenic, so it's not used in pregnancy. I think so far the only drug that I've discussed so far that is used in pregnancy is the alpha methyl dopa, the aldomate. That's the only drug as of now that you have seen that the only antihypertensive drug as of now that is being used to for this class in pregnancy. We're going to look at other drugs like the hydralazine later, but for now we know those are the drugs that are only used in hypertension in pregnancy. So exposure during why the reason why it's not used in pregnancy is because if you expose the fetus on these drugs during pregnancy, especially during the second and third trimester, it can cause fetal toxicity, renal failure, oligohydramnios, skull hypoplasia, and death. So it's not used in pregnancy. That's a point that you have to know. So that being said, let's continue. Let's look now at our aldosterone antagonist. Now, I'm going to explain this well when you look at our next topic on diuretics. When we look at potassium sparing diuretics, I'm going to explain better on how this happens. But remember, aldosterone hormone is a very crucial hormone that's always released in the adrenal cortex. And this hormone, number one, what it does is that it acts on the renal tubules to cause the sodium retention or reabsorption and water reabsorption, but it also leads to excretion of potassium. So when you stop this hormone from functioning, it means you're going to retain potassium. So that's one of the mechanism of action when using the potassium sparing diuretics. But I'm going to explain it well when you look at when we discuss our next topic on diuretics. So they only reduce sodium and water retention. These are the spironolactone and the eplerenone. So the spironolactone and the eplerenone, they're also called the potassium sparing diuretics because they act against aldosterone. So remember, you have to watch out for hyperkalemia. Watch out for hyperkalemia when using those drugs. So this is our one of the potassium sparing diuretic, the spironolactone and the eplerenone. So these drugs are the aldosterone antagonist, but they can also be called the potassium sparing diuretics. So these drugs also can be used when it comes to managing hypertension. Let me just go through mechanism of action in a while. Now, aldosterone antagonists are structurally similar to aldosterone and act by competitively binding to the intracellular mineralocorticoid receptor. So by preventing the aldosterone from binding, this agent causes the inhibition of sodium reabsorption. They inhibit the reabsorption of sodium, and we know that when you inhibit sodium reabsorption, it means you are also inhibiting the water reabsorption. So it causes a mild diuretic effect. So another one here, inhibition of potassium excretion. We know this one of the major action of aldosterone hormone is that it leads to retention of potassium. So retention of potassium and hydrogen, giving the classifications as potassium sparing. So apart from retaining potassium, it also retains hydrogen ions. And that being said, we know that if you retain hydrogen, you are going to lead to metabolic acidosis. Okay, now hyperkalemia, I've explained how this happens. This is one of the most critical life-threatening adverse effects. It also has got endocrine effects. This is something that you have to understand. This spironolactone, to be more specific, it may cause gynecomastia. Gynecomastia means man boobs. Yeah, man boobs. Breast tissue development in males. You may see the males having breast. which looks very abnormal, breast tenderness, and decreased libido. So it also leads to that. As I said before, it may lead to metabolic acidosis. Why? Because it also leads to the retention of hydrogen alongside potassium. So it may lead to hypochloremic metabolic acidosis. It may also have an impact on the CNS. How? It may cause dizziness, headaches, lethargy. This is secondary to mild dehydration and electrolyte shifts. Remember, these drugs leads to sodium and water excretion. And when you excrete sodium and water, it may lead to mild dehydration, which may have an impact on the CNS. Now, I want to show you man boobs. Man boobs. Those are the man boobs that I was trying to explain. The gynecomastia. So this is one of the impact, also the effects of using the spironolactone. So in spironolactone, it not only blocks aldosterone hormone, it also blocks the androgens. And that being said, it may cause gynecomastia. So don't forget that. Now let's look at our last classification of drugs. These are the renin inhibitor. Now I've just put here inhibitor because I only know of one drug that falls under this category. That's why I've put inhibitor, a singular topic. Now, direct renin inhibitors, they represent the newest class of pharmacological agents that target the RAS system. Now, while the angiotensin converting enzyme inhibitors and the angiotensin receptor blockers act downstream, direct renin inhibitors target the very first rate-limiting step of the cascade. Remember, the first cascade of the RAS system is always the release of the renin, the production of the renin from the juxtaglomerular cells. So what if you can just stop that first start? You're stopping the production of renin from happening. Yeah. So that's how this drug acts. They just stop the renin production. So the only clinical approved drug here is the drug called aliskiren. This is the spelling. Pronunciation may differ depending on your accent. For me, I think it's called aliskiren. I think that's the right pronunciation. So it is primarily indicated for management of essential hypertension, either as monotherapy or in combination with other antihypertensive agents. To be honest with you, in my practice, I haven't come across it. But if you've come across it, please type on a comment section why it was used and how you used it. Please let us know how you used this drug. For me, I haven't come across this drug so far, but I got it. I saw it. I googled it in Chrome and I saw an image of it. So adverse effect here can cause GI distress like diarrhea. It can cause hyperkalemia. Remember, if you impact the RAS system, you will lead to potassium retention. It may also lead to hypotension. Obviously, one thing that you have to know is that one of the adverse effects of using the antihypertensive is always hypotension, because the antihypertensive, they try to decrease blood pressure. They may decrease blood pressure massively, leading to hypertension. Don't forget that. So we can't use this drug in pregnancy because it's highly teratogenic. Also, we can't use this. We also contraindicate it being used concomitantly with the angiotensin converting enzyme inhibitors, called the angiotensin receptor blockers. And this is the drug that this is a drug that I found from one of the websites. This is what it looks like, but for me, I haven't come across it. So if you have seen it somewhere, please let us know. We will appreciate. Wow. So that's all of our class. So for now, we have discussed our third episode on antihypertensive. We have looked on the drugs that work against the RAS cascade. We have looked on the angiotensin converting enzyme inhibitors, the prils, and you know that the prils, they're very good drugs, especially for those clients with the DM type 2, because they reduce the glomerular pressure. Don't forget that. But apart from that, the angiotensin converting enzyme inhibitors, they may have serious adverse effects. Yeah, they may cause edema, angioedema. They may have dry, persistent cough because of increased bradykinin levels. Apart from that, they may also lead to hyperkalemia. So be very vigilant. Know signs and symptoms of hyperkalemia, because you can easily detect an overdose or an adverse effect of using the angiotensin converting enzyme inhibitors. Apart from those drugs, remember the prils. Don't forget the enalapril, the captoprils, and the rest. Now, apart from that, we have looked on the angiotensin receptor blockers, and I've looked at the statins, the losartan, the candesartan. So don't forget those drugs. They're very similar to angiotensin converting enzymes inhibitors, but for them, they have no impact when it comes to bradykinin. Apart from that, they also cause hyperkalemia. Don't forget that. Another drug that we have looked on renin inhibitors, the aliskiren. We have looked on the aldosterone antagonist, the likes of the spironolactone and the eplerenone. But I've said that those drugs, the aldosterone antagonists, are going to look at further when we look at potassium-sparing diuretics on our next class, when you look on how diuretics impact our blood pressure. So that being said, I want to be very thankful for you guys for being patient. The class, I think it's around 40 minutes if I'm not wrong. It was a nice class. I hope you guys now have understood some of the drugs that work on the RAS system. If you're new to the channel, please support us, guys. I know the camera is not clear right now. The voice is not clear. We are trying to improve per episode. In future, we're going to have a very good mic and a very good webcam camera. But for now, we're just trying to use what we have. My aim is to ensure that we are able to understand what we learn in our class better. For those who are studying for pharmacological classes, we can understand better. For those guys studying for physiology and anatomy, we're going to increase our videos to also capture some of the physiology topics and some of the anatomy topics. But for now, this topic, I hope you guys have understood what we have discussed. If you have heard anything that is contradictory to what I've said, please comment for us to learn together. This is a learning session. No one knows more than the other. You are trying to understand as a team. Please post it in the comment section. Share the link. Largely, I want us to have a lot of subscribers, a lot of views. Our aim is to have a community, a group, whereby we can help each other understand some of the crucial topics that we discuss in our class and also in our facilities where we work. Thank you for everything. Thank you for your patience. And I hope that God bless you all and that you may have